So the first question is there any pre or post bronchoscopy medication suggestions and any suggestions for post bronchoscopy recruitment maneuvers? So in terms of the medications for bronchoscopy, we truly don't have to use any medications on these patients. The only thing that I see all the time, and I see reports from bronchoscopies from our patients, from patients in this area, or from donors that are offered to us for transplantation from any different states. And in our program here at NYU, we go pretty much all over the country to pick up organs. And when I look at the bronchoscopy report, one thing that I'm always like, I don't understand why they do this. They go ahead and do the bronchoscopy. They report that there is a fair amount of secretions. And then they say, we did a BIL with 12 cc's of saline and come out. And when they do those 12 cc's of saline, they may be lucky to get 6 cc's back and they come out of that area. And so you asked me about what is the medication to use. We're going to have at least 2 syringes ready with 60 cc's of saline. And we're going to ask them, okay, keep going and cleaning up everything that you can. And if you see an area where there is a lot of mucus or there is plugging or the x-ray show that there is complete collapse of the lower lobes, I want you to go into the lower lobes and put a lot of saline and see you can start removing some of those plugs. The concern is always, okay, do you put a lot of fluid and then the x-rays are going to look really bad or it's going to be more hypoxemia because of that? So the hypoxemia, because doing the lavage again with 120 or 200 cc's of saline will never happen. It may happen that while you are doing the bronchoscopy, there is some de-recruitment or in a patient that is more unstable and you lose the PEEP and do things like that. So those things, and I will go in a second over the answer of those 2 questions, but it is important to educate them and say, okay, you see areas when there is some mucus plugging or that there is some purulence or even a little bit of an aspirated material. We want you to be aggressive with this, clean it up. And once we clean up the airways, put another 50 cc's of saline, get it back. And you say, okay, I don't see any purulence coming back. The fluid is starting to come very clear. We clean up the airways. So these in some way are more like a diagnostic and therapeutic bronchoscopies. Extremely important to do this, rarely done. And it's part of this idea that all you have to do is to do like an exploration of the airways and look around and give me a sample for a quick BIL. I don't think that's what we are asking about bronchoscopy. We're asking a bronchoscopy that is truly going to help the patient, especially when you follow with the x-rays. And this is another point that when we do our simulation course and we are training the coordinators that have been in our OPO for a while or the new coordinators, and I say you have to put the donor management, everything into context. It's not a bronchoscopy by itself. It's a bronchoscopy as a result of a blood gas and x-rays that you are looking. You look into the x-rays, and that's why I always say it's so important to look into the x-rays. And we have a sessions again dedicated that we could do in the future just about donor x-rays. How can, again, a coordinator look at the x-ray, or at least ask one of the physicians that is there and say, what do you think is the predominant factor? Because very often when you look into the x-rays of these patients, it's going to be the x-ray number 20 or 25 that has been done in this patient. And the radiology basically copy and paste the results of the day before. And very often you're going to see the results like this. Multiple infiltrates, warts on the basis, cannot rule out atelectasis versus pneumonia and maybe a pleural effusion. It doesn't help you. Again, it has to be a predominant factor. And you have to say, okay, I think that there is a pneumonia. So when you go and do a bronchoscopy, thinking that the patient possibly has a pneumonia, what do you need to look for? Okay, I think that there is a pneumonia on the right lower lobe. I need to be sure that the bronchoscopy and the bronchoscopy specifically, again, goes into that area. That's a large volume BIL, clean up all of that secretions and see there is purulence. And after you do all of that, at the end, is that fluid coming back still purulent? And then you can say, no, okay, looks good. Again, a little bit of purulence, but it didn't keep coming back. This bronchoscopy, because of the purulent fluid, confirms the diagnosis that we have of possible pneumonia. We need to be sure that this donor is going to be on antibiotics, which, by the way, every single donor should be on antibiotics. It's a mute argument that people ask, why are you starting this on antibiotics? Because these lungs are going to be on antibiotics 24 hours from now when you go into the recipient. Every recipient in every transplant program in the world receives antibiotics. What is the problem to start the antibiotics early? But if you didn't have antibiotics, then you have even a stronger argument to use the antibiotics. If you see that the donor has problem with atelectasis, and you see the predominant factor is atelectasis, is this kind of dense white consolidation in both of the bases, I cannot see the diaphragms, which means if you see that in both of the lower lobes, it's just you are basically just working with one lung, because once you collapse both lower lobes, you lose a full, again, entire lung on that process. So all your mechanical ventilation is going to be a lot more difficult. Even if you try to do recruitment and the lungs are plugged with secretions, you cannot get the air going around that mucus and open those lungs. So you have to do a bronchoscopy. And that goes a lot about some of the questions that we will come in the future about the timing of this. You have to see the x-rays. You have to do this. But going back into the question, what is the medication? Again, the Shane is asking from Donor Alliance. To me, the medication is load yourself again and the team there with saline. Very commonly, I have to say that when I do the donor bronchoscopies in our institution, in the donor center that we have, easily I'm using between 250 or 300 cc's of saline. So that will be the medication. Now, there are some people that talk about using some mucomis. There is, again, really thick, deep mucus that you cannot break very easily, which is okay. You can even use the mucomis with the bronchoscope or just kind of give some treatments with mucomis or hypertonic saline. That is probably one of the ones that is better for these issues with mucus. You can do that. Now, do you have to use a bronchodilator? Not necessarily. Again, if you think about asthma in a brain-dead patient, it's very rare to have a lot of bronchoconstriction, and you see some of the patients with asthma that die because of an asthma episode. And in some way, actually, the asthma gets better once they get pronounced brain dead because they lose some of that kind of innervation between the brain and the airways. So it's not necessarily, but yes, if they have some evidence of bronchospasm, high peak pressures, yes, it's perfectly fine to give a bronchodilator, but it's not the reason that, again, to have to give it to everybody.